Hello, everyone, and welcome to today's webinar on Niagen Plus. We are pleased to introduce our presenter, and Eric. Eric is the Chief Revenue Officer at Wells Pharmacy Network. He also serves as a consultant for Niagen Bioscience, where he supports business development and commercialization. He was actually instrumental in the launch of Niagen Plus and brings over 26 years of experience in the pharmaceutical and biopharmaceutical industries with deep expertise in lab testing and healthcare strategy. So I'd like to welcome Eric, and I'd also like to give a special shout out to Jerry Germain, who is an amazing executive sales rep with Wells, and he is the one that brought this opportunity to our network for MPC and our telewellness affiliates. So without his he's been working really hard on getting this here so that we could get this webinar today. So I'd like to thank him as well for that. So without further ado, Eric, we're going to launch it off to you. And just for everybody, he's going to go ahead and give about a 25-minute presentation. And then we're going to open it for Q&A because we feel like there's going to be a lot of questions and talk around that. So go ahead, Eric.
So good morning, good afternoon, everybody. Really excited to be here and have this opportunity to just chat with the entire MPC network about NAD boosting, and in particular our disruptive new technology Niagen Plus and the role that it plays in all aspects of cellular and mitochondrial health. So just to kick things off, what I wanted to share is and state is that NAD is having its moment right now, right? Many of you may be hearing and seeing it if you're going to trade shows, regardless if they're anti-aging trade shows, you go to these cosmetic trade shows, there's NAD in so many different delivery modalities right now, from dietary supplements to obviously the sterile formulated stuff. You're seeing it in patches and nasal sprays, on and on and on. And then when you just look at social media and the adoption that that it's having around the all aspects of NAD boosting, it's definitely making its way to prime time right now. So the objectives for today, I'm going to spend a little bit of time talking about NAD therapy and why it's important. We're going to make some general assumptions around just that many of you have a general understanding about NAD, so we don't spend too much time deep diving into that, but we'll talk about it at a high level. Then we'll transition into Niagen itself and its hero ingredient, nicotinamide riboside, right? And then from there, we'll explain some of the biochemistry differences so that you can best educate your potential patients, and then eventually transition into what sterile formulations are available, how it differs from the patient and the clinic experience with NAD. And then ultimately, we're going to talk about the product portfolio, what's available through our 503B as well as our 503A. And then we'll finish there and really jump into the Q&A session. All right, so as I mentioned, from a high-level perspective of NAD and the role that it plays, at the end of the day, it's about energy production and cellular defense/repair, right? To the layperson, and what you see in terms of marketing out there is it's about performance and recovery, which ultimately, is coming from the energy that's produced and how quickly we're defending and repairing, right? And so I won't get into crazy detail here about PARPs and sirtuins, but you'll see that it's really about just energy production and repair, like I've stated, right? Now, all of us are exposed to the same constant, and that's aging in time, right? It doesn't matter if we're talking about NAD therapy or a lot of the other interventions that you see out in the marketplace right now. Age is a constant that impacts all of us. And as you see here, from the age of 30 to 70, our NAD levels typically decline by as much as 65%. If you think of an analogy of a cell phone, right? When we buy our brand new cell phone, doesn't matter what brand it is, it fully charges quickly and the battery lasts, a really long time. But as we use that cell phone over time and we beat it up and everything else, the battery will just naturally decline. So even when you plug it into your wall, what have you, and charge it up, it never really fully charges to 100% again. In fact, a lot of times your battery starts dying much quicker, right? And then some of the apps on your phone become outdated because you might have an older model cell phone and new apps are coming out that require more storage, and so those don't function as well. And that happens with us. Certain things within our body don't function as well when our NAD levels are lower than and in suboptimal state. Now, besides age, we're all exposed to different metabolic stressors, right? Literally each and every one of us will have different stressors. And put a pin on this, because as we start talking about, or going through the Q&A session, one of the most common questions I get is around protocols, right? How often should we recommend this to our patient? Well, I just mentioned age is the constant, but what's not a constant are a number of these other metabolic stressors. You have athletes that overtrain. You think of right now it's summer, football, professional athletes and collegiate and high school and what have you are doing two-a-days. They're exposed to a lot of stress from the training side of things, right? You have those that are going on vacation, a lot of sun exposure, travel from the exposure being on a plane with recycled air and COVID, on and on and on, to lifestyle decisions that can heavily deplete your NAD levels. So all of this will factor in how much you need, and how often you need it. This is just an example of how NAD depletes, right? The exposures that I just referenced, from sun exposure, alcohol consumption, a sedentary lifestyle, on and on and on, that is going to put strain and then start impacting the consumption and the need for NAD, right? And it plays a role on our cells. So that's where our mitochondria and our DNA is. That ultimately translates to cellular damage when we're over consuming our NAD levels. And then what that does is that will activate the PARPs and sirtuins that ultimately upregulate more and more of the NAD consumption, right? So here it's about production and consumption. Our bodies naturally are producing NAD, but our bodies are also naturally consuming NAD. And there's going to be a point in time where we're consuming more than we're producing. And that's that age variable that I mentioned that plays that biggest role. And then ultimately all those other metabolic stressors that I described. Okay, so what can we do as individuals to mitigate this loss and to impact that balance between what we produce and what we consume? And that is really these bullet points here on the left. We can control our exercise, our healthy lifestyle, from diet to the decisions that we make. Caloric restriction plays a big role in things, right? And then just minimizing the exposure to those metabolic stressors that I mentioned before. But at the end of the day, you can do all of this, but it will reach a point where we're still just not producing enough. And that's where supplementation comes into play, right? In the way of different delivery modalities. You'll see here images of an IV bag, and then also like a dietary supplement that we'll talk about in more detail as we go through this. Okay, so the earlier slides, I breezed through those, but I wanted to spend a little bit more time on this particular slide, take us back to our biochemistry days, because what you'll find is that education is going to be a critical component for all of you as providers and for your staff when it comes to educating the patient population, right? The layperson out there is hearing about NAD and all the value that it has. They hear the buzz marketing terms around cognitive health, right? Less brain fog, energy, and a number of other things. But why? What is the difference between NAD? What is the difference between precursors like nicotinamide riboside, NR, or others like NMN, on and on and on? What I'll start by saying is all these molecules play a role, right? It's a matter of which ones are most efficient at which point in time in the biochemistry process that impacts all the metabolic processes that are in our body. Okay, so let me see if I can get a laser pointer here. Okay, so if you look at the bottom left here, you have the structure of the NAD molecule. It's a small molecule, but it's relatively bulky. You'll see it, there's a molecular weight in the 660-ish range, right? Also here depicted, these two red molecules are negatively charged phosphate groups, okay? So these are two pain points of the molecule. Ultimately, our goal is to get NAD into the cell because that's where the magic happens, right? Inside the cell, the NAD coenzyme fuels the mitochondria that ultimately powers those 500 plus metabolic processes that are in our body, right? Now, the challenge with NAD is, those two things that I just mentioned, the size of the molecule and the phosphate group, that prevents it from coming directly into the cell. So earlier I was talking about different delivery modalities. Doesn't matter, IV, sub-Q, IM, patch, nasal spray, dietary supplement, it has to start extracellular. But because of those two challenges, it doesn't have its own ability to get into the cell. So what the body is doing is it's responding in an inflammatory way, right? We're supplementing and delivering NAD, but the body is looking at it as a foreign object in its extracellular state. So that inflammatory response, keep in mind, we'll talk about in greater detail when we talk about the interventions, ultimately are the rate limiting factors. Now, when you look at Niagen and its hero ingredient, nicotinamide riboside, it's a precursor to NAD. It represents 38% the molecular weight to NAD, and it doesn't have those negatively charged phosphate groups, right? So then when you compare in its extracellular state, NR is the most efficient. It has its own VIP red carpet to get into the cell, whereas NAD, as I mentioned, has to break down and ultimately find certain of the metabolites of the NAD molecule will eventually get into the cell. So NR is the most efficient of all the molecules. And once it gets into the cell, in two simple steps, it will convert into NAD. Okay, it looks like somebody drew on here. So quick call outs on this slide. Nicotinamide riboside is a rare form of vitamin B3, okay? And so it's a water-soluble vitamin. So that is important because when we talk about the molecule and its use case, being a water-soluble vitamin, it's going to play nicely with other molecules. Where NAD, I like to refer to it as kind of the bully on the playground, and NR is that popular kid. So we'll talk about how that impacts some of your decision-making when you're offering it to your patients. Okay, what can we call out here? So the product, the company Niagen Bioscience, formerly known as Chromadex, was a dietary supplement company. I'm showing a bottle of True Niagen. That's been around for over 10 years now. But 3 years ago, the company nominated the molecule nicotinamide riboside to be added to the Category 1 503B bulks list, and it was accepted, right? And so what that did was it kicked off a chain reaction of events. Where when I was at Niagen, what we did was we started vetting out CGMP FDA registered 211 CGMP facilities to manufacture the pharmaceutical grade API. And why is that important? It's because if you think about NAD, it's a commodity. It's a commodity that even the FDA has put out a memo and stating that they know that it's not well regulated right now, and that a number of compounding pharmacies have actually been using food grade quality. And so because of that, there have been a number of challenges from the microparticulates and more importantly, the endotoxin levels that have varied from compounder to compounder and even batch to batch, right? And that translates to compliance risk and risk for US providers and your patients. Well, with Niagen, what you have the peace of mind is it's being manufactured in the States and abroad at FDA registered facilities. And because of that, our third-party testing lab has found that from endotoxins, microparticulates, and bioburden, on and on and on, it's literally been the first molecule in the 9 years of existence of this third-party testing lab that they've seen scored 0 across the board. So you have peace of mind as a provider that the product is as compliant as can be. So when you're recommending this as an intervention offering, you don't have to worry about those concerns. I'll talk about how it's terminally sterilized in a bit as well. Okay, now let's go on to the sterile formulations. For those of you that may already offer NAD therapy, and then of course for those of you that may be new to this, the rate limiting factor are the side effects. So if you think back on that biochemistry slide that I talked about, that inflammatory response that the body is having when you introduce a high dosage of NAD, that is what ultimately translates to an individual's tolerability, and then that then cascades into the time and share. Your typical 500 milligram NAD infusion in, let's say, a 500 cc saline bag typically lasts between 2 to 4 hours. You're going to have your NAD warriors that try to suck it up and do it in an hour and a half. And then you're going to have many that are even beyond 4 hours, right? And ultimately, that is just their tolerability, right? But regardless of how they tolerate it, it's still inflammation. And we've done a clinical IRB study, and we measured a number of biomarkers, and I'll share that with you on the next slide. But 2 of the key biomarkers, basophils and neutrophils, are representative of inflammation. And with the NAD cohort group, by far, the delta from before and after they did their infusions was dramatic, right? And that truly points out that inflammatory response. And that's what really leads to the nausea, the heart palpitations, the GI distress, and all those other lovely side effects that are common of NAD, right? And so because of this, the retention rate for NAD therapy with the patients is relatively low. People will come try it once and they'll realize this really sucked. And so I don't want to do it again. But there are people that realize that the pros outweigh the cons, and the benefits of cellular health, mitochondrial repair and proliferation outweighs the pain points, right? So they will continue to do it. But it's limiting because it's hard to cater to the masses when you have these adverse side effects. Now, when you think about the Niagen experience, it is night and day difference from the NAD experience. And the reason, if you go back to that biochemistry slide where I talked about that VIP red carpet to get into the cell, because of that, the body doesn't have that inflammatory response. And so the common side effects that are seen by NAD don't exist. It doesn't mean there aren't side effects. There are potentially some side effects, but they're minimal in nature. The most common side effects are a tingling sensation that happen in the jawline here, right? And the hypothesis is that it's an electrolyte imbalance that happens. When you infuse high level of water-soluble vitamins, from time to time, you may experience this electrolyte imbalance. But what we found is that electrolyte imbalance, the feeling is like pop rock candies in your mouth, right? And 5-10 minutes post infusion, the electrolytes will normalize and any of those sensations will go away. To a much smaller degree, some people will experience a jaw tension, a soreness. And the hypothesis there is it's that same electrolyte imbalance, but it's most likely attributed to individuals that may have a prevalence for TMJ. They do a lot of teeth grinding. So they already have an IA nerve here in their masseter muscle that is inflamed. And that electrolyte imbalance is ultimately just exacerbating the inflammation. But same story, when the electrolytes normalize, 5-10 minutes post-infusion, even that tension or soreness will go away, right? So when you compare the potential side effect profile, it's just disruptively different. So that 2 to 4 hour infusion by NAD, now with Niagen, is about 30 minutes. Plus or minus 10 to 15. So the experience is more like a Myers cocktail than it is an NAD infusion. So your patients are going to be more willing to come back, right? From an opportunity standpoint in your clinic, whether you have 1 or 2 chairs or you have an IV center with 8 to 16 chairs, that real estate is those chairs are real estate, and that is opportunity to you as a provider, right? Your nurses are going to be able to manage more patients at the same time, as well as more patients over that same body of time. And we already talked about the compliant aspect of the molecule, right? Another product. What we haven't talked about is the efficacy standpoint. And what I could probably do is just jump into this next slide here. There's a hyperlink here. So the MPC team will send out a follow-up email and include this presentation deck. And this hyperlink is to the print, right? That's on clinicaltrials.gov, where it will highlight 40 pages around this study. There were 4 cohort groups, and this is a double-blinded study where we looked at the Niagen cohort group, the NAD group, the placebo with saline, and even the oral arm. And we measured intracellular NAD levels, right? But we also did the famous draw to look at CBC, CMP, heart, kidney, liver function, as well as those inflammatory markers that I mentioned. And that's where a lot of the results came from that we can discuss here, right? Yeah, ultimately that's what the data is coming from. This just summarizes what I've discussed already. What I failed to discuss up till now is the efficacy standpoint. Like I mentioned, we looked at the intracellular NAD levels, and what we found was that the 3-hour mark post-infusion, you'll see that the intracellular NAD levels are greater than 20% higher with the Niagen cohort group than with the NAD cohort group. And then it carries for the first 24 hours, right? So if you think about that biochemistry slide that I talked about, how Niagen directly enters the cell, that supports that narrative here, right? And what the NAD has to break down, so because of that, NAD actually doesn't increase in the first 24 hours. It eventually breaks the molecule down, and then some of those metabolites will increase the NAD levels, but it doesn't happen immediately. All right. We talked about all this. Let's jump into the product portfolio itself. So as I mentioned earlier, Niagen is available from our 503B as well as our 503A. And the MPC team will explain to you how to onboard and have access to these products. But from a 503B standpoint, it's for office use, right? So you don't have to write a script to get access to the product. The product is going to come terminally sterilized by e-beam as a powder. So when you receive it as a powder, you have options. If you reconstitute that powder with sterile water, then it's preservative free and it's a single-use vial. So it's very common to put that entire 500 milligram Niagen powder that's been reconstituted into a saline bag, right? Now, if you reconstitute it with bacterial static water, now you have more options. You can still reconstitute it and put it into your 500 or 1 liter saline bag for use once. You could use just a portion of it to make like a smaller IV bag, or you can blend it with other IV nutrients. If you recall earlier, I talked about it being a water-soluble vitamin and that it plays nicely. And so if you offer Myers cocktail, a lot of water-soluble vitamins in there, right? And it won't be the rate-limiting factor like NAD will. NAD will blend with your Myers cocktail, but it becomes that bully on the playground to where normally if you did a Myers, it might take 20, 30, 40 minutes because it's just the sheer volume of fluid. But once you introduce NAD, then it's going to take you 2 to 4 hours. But with Niagen, it's going to behave like it would as it will assimilate in with that Myers cocktail bag, and you'll get your typical 30-minute infusion time. You can also, draw out 50 or 100 milligram dosages of the Niagen product, and you can do IM for local injections, or you could recommend subcutaneous offerings as well. Now, when you go over to our 503A, and I believe many of you are already on the Wells WPN platform, that's where we now are offering an at-home injection kit. So it's the same product that is a powder coming from our B, but we've transferred the product from our B to A and we've kitted it. We've included a number of these other components so that your patients, if they don't have the ability to get into a clinic, or if you have a telehealth component to your clinic offering, you can write scripts and we can ship to the patient's home. Another use case opportunity is, if you think about it, if they come into clinic and they receive their IV, that's where they're getting, a real detoxification, a powerhouse, or excuse me, a power wash of their cellular system. And then what they can do is get the Niagen at-home injection kits to have maintenance in between their scheduled IV protocols that you may put in place with them. Okay. All right. So at this point, we're towards the tail end of the presentation. I'd like to pitch it back to the MPC team, or to you folks as providers to answer any questions that you may have.
What would recommended dosing frequency be for this?
Yeah, we prefer to leave that decision to the provider relative to their outcome goals, right? But when I am asked this question, I usually break it into 3 buckets. Where is NAD commonly used right now, right? And from a sterile formulation standpoint, right? You see that NAD is used quite a bit in that rehab center, the detox world, right? That's where NAD really was put on the map. And in that lane, typically providers will be recommending to do NAD therapy for upwards of 2 weeks 1,000 milligrams to 2,000 milligrams a day. In that space, we've been working with providers and getting them to incorporate Niagen. And what we found is that they're able to reduce the total infusion time and satisfy those same goals of blocking that that craving addiction that is common, right? So that's the detox rehab lane. Then you see use case wise for the ketamine world, where they're doing a lot with PTSD, depression. I group Lyme disease and autoimmune disease kind of into this world as well. And you tend to see this middle range of 1 week to 10 days of protocols, right? And what we're finding there, same story. Doctors, providers that are incorporating Niagen, because it's well tolerated, are now getting shorter total protocol times, right? And then the last lane where most people are landing is the general wellness vitality world, right? And so this is really a bit of the wild, wild west right now. And a lot of the providers that we've interacted with have already set precedent on their existing protocols with NAD. And their inspirations were the few internet searches that they did or information they got from the detox world. And so what we typically see here is some type of loading dose, right? If you think of the analogy of a leaky bucket, all of us have a leaky bucket. So it's how do we fill that leaky bucket? And typically you do it with some type of loading dose. It could be the first infusion is, let's say, 1,000 milligrams, or it could be multiple 500 milligrams week 1. And then if you recall, I talked about the various metabolic stressors that are going to be unique to us, right? So depending on how each individual's metabolic stressors play a role, their NAD levels may decline over the course of 2 to 4 weeks, right? If you're not doing anything to supplement. So a protocol may fall in the way of a 2 to 4 week come back and then do some type of maintenance in between those 2 to 4 weeks with the at-home injection sub-Q or like the dietary supplement, right? Does that help answer it a bit, Amy?
Yeah, I guess I should have phrased it a little bit better. Just really was it consistent with current NAD dosing, I guess would have been a better.
Yeah, yes. So we typically recommend take your current NAD protocol because it's just gonna do more than NAD does right now, right? So you can take that protocol and then over time start catering it to, okay, I don't need to do as much with NAD because it's more efficient.
Perfect. Thank you.
You're welcome.
So we have a question. Is this a sub-Q injection?
Yeah, so it's potentially all of them to that question, right? So if let me share my screen again. Okay, if you recall here, if you're acquiring this from our 503B, it's a powder. So once you reconstitute it with bacteriostatic water, you have the option of IV, sub-Q, or IM, right? Typically, what we see in brick and mortar is IV and IM because you have a provider that can actually administer it, right? We don't, encourage or see people doing IM at home too often. Whereas what they'll typically do at home is sub-Q because they've already been Pavlov to do this with the GLPs and peptides.
All right. Would you use this in combination with NAD, or why would one want Niagen versus NAD?
So there are, we're still early in our understanding, right? As I mentioned, every molecule plays a role, and there is a school of thought that extracellular NAD, even though it causes inflammation, when it breaks down into its various building blocks, there are certain metabolites that may be doing something that we're not clearly understanding. For example, adenosine. Adenosine is a metabolite of the NAD molecule, right? And for those of us that, may come from an ER setting, we know that we use adenosine, especially in high dosage, to flatline somebody that may have AFib, right? And then we want to convert them to bring them back. And the thought is the low level of adenosine may be doing something. So if you as a provider think that there's a benefit to adenosine, and really where that may happen is in that detox world, then yes, NAD and Niagen NR in combination can provide some value. More times than not, you don't need NAD by these other IV or these other delivery modalities. You can just use NR because it's going to get into the cell and it's going to convert into NAD quickly. So more times than not, you're not going to need the NAD product.
All right. If I let's see, how long can you safely store NR for sub-Q when reconstituting with non-bacteriostatic water, or is that not encouraged?
That's not encouraged. The FDA guidance is that after you puncture your vial and reconstitute it with bacteriostatic water, you can refrigerate it and it becomes a multi-dose vial that you can puncture multiple times, obviously, for up to 28 days.
All righty. Here's another question. If I do a loading dose of NAD 750 mgs once a week for 3 weeks, is this the same for Niagen? Then I do once a week for maintenance 500 mg. And I know you really can't speak specifically to dosing, but could you say that that's comparatively the same?
Yes, I would just like the answer with Amy. Follow your current protocols that you have with NAD that you plan to do with Niagen, but just expect better overall outcomes.
Someone just asked, are there any contraindications for using Niagen?
Yeah, very good question. So right now at this point, what we defer to is contraindication is cancer and pregnancy. And really it's because there's just not enough information out there, studies around the two. I would argue that there's pros and cons for cancer. And I would argue that it's actually beneficial for pregnancy. But at this time, we'll say contraindication is those two classes. I can also just share this. This is usually a common question. What's the beyond use date right now, right? And so the product, the stuff that is currently on the shelves at our 503B has an expiration date of November 5th and November 8th. And that is off of a recent approval for 120-day beyond use date. As of last Friday, we just got approved for 180-day beyond use date. So more than plenty on the the expiration date right now. So everything that we're going to be making moving forward, we'll have that 180 days, and you folks won't have to worry about discarding quickly.
And then they just wanted clarification. Is it a history of cancer for the contraindication, or someone that is currently diagnosed with cancer?
Just right now, overarching, anyone that's had cancer, current or previous, due to just not enough data at this point, right? But like I said, I could argue one way or another on that.
And then someone wants to know basically the price point for NAD versus Niagen.
Yeah, you'll see pricing on the MPC platform at some point. I will say overall, the Niagen is definitely more expensive as an individual vial, right? So if you look at it as a COG, from a vial standpoint, it is priced higher than NAD. But if you think about some of the things I talked about before, it's compliant, it's pharmaceutical grade, it's not a commodity. like NAD is. There's 94 patents around this technology. And we've taken all the measures to approach this from the most superior way possible, from terminally sterilizing it, what have you. But then when you think of the overall opportunity and how you reduce your other COGS, the nurse COG is reduced, the opportunity cost is increased. Holistically, the cost all in is significantly lower than just the vial of NAD.
And patients come back.
Patients come back, absolutely.
And for, I believe for office use, it is a 4 vial minimum, correct?
That's right. Yeah, thanks for pointing that out. Yeah, so yeah, office use, it comes in a 4-pack. The at-home kit, of course, individual.
I stepped away for a couple of minutes. I'm sorry if you covered this. Could you speak to the absorption of the oral modality, just, compared to the IM sub-Q?
Yeah.
If you're looking at what you're doing in between IVs for maintenance.
Yeah, so I mean, naturally, when you're taking any type of dietary supplement orally, you got to bypass your gut, right? So we'll be lucky if 10-20% gets past our gut, especially when you're thinking about NAD therapy, right? Because our gut wants NAD just as much as any other tissue or organ in our body. And so you have to really take a lot of a food grade dietary supplement in order to boost your intracellular NAD levels. And then also how much of that actually gets into the tissues and organs beyond, right, is still fairly unknown. Now, when you do something by sterile formulation, you're going directly into your bloodstream, regardless if it's IV, sub-Q, or intramuscular, right? The bioavailability is still not clearly known, the difference between IV, sub-Q, and intramuscular, but we did just do a second clinical IRB study comparing 100 milligrams across all 4 of those groups, the IV, sub-Q, intramuscular, and the oral. That's still months away from being printed. But that is going to be valuable information for all of you in time.
Thank you.
So far, we're good on the questions. Does anybody else have any questions? Oh, let's see. I use, great, niacinamide and niacin combo for oral. Does your oral product the same?
So they're different. Let me do this again. So let me go back to that biochemistry slide real quick. Okay, you recall this slide, right? And I think the question was niacin or niacinamide. You'll see nicotinamide here. So all of these have a different salvage pathway to get into the cell. And if you recall, I talked about efficiency, right? NR is the most efficient one. Niacin has some of the properties that you can NR will have, but it takes more steps. So the more steps it takes, the more energy you have to consume before you produce energy, right? Also, niacin is notorious for flushing. So there's a large percentage of us that will get this flushing. I'm one of them. If I take niacin, I get all red, and you get some of those side effects that you get from NAD. With nicotinamide, it's a longer roundabout way to get to converting to NAD, and there's some school of thought around. There's some negative aspects of what happens when you take this particular salvage pathway. So to answer your question, they all will eventually produce NAD. It's just a matter of efficiency.
We got another question. What are your favorite regenerative therapies / peptides to pair or stack with NR?
Ooh, okay. If you think about this from the thought of cellular health, mitochondrial health, the opportunities are literally endless, right? And we're really at the beginning of things, right? From, like I said, a wild west standpoint. right now I've been talking to a number of providers and about the use case where you're treating your weight loss patients. If you think about weight loss, the two most common side effects are nausea and heart palpitations, right? I'm sorry, nausea and lethargy. And so if you think about cellular health and what I talked about with NAD therapy, you're increasing your cellular energy. So you're able to help increase your metabolic response, and then you're also generating more energy to combat that lethargy that's common of GLP. I have a provider that just shared with me, they had a patient on one of the GLPs that plateaued after a while, right? We know it's common that weight loss our patients will plateau. They put them on a Niagen protocol, and in 2 weeks, they lost 13 more pounds. That is one N of one scenario. The thing is, there are a number of these N of one scenarios that will start forming some common theme. And so that's one that I found is pretty powerful. In fact, now that provider is booked dozens of patients, and they're looking to work with us to put out some type of study in time, right? That's one example. So if you just think of energy and you think of repair, if you think of those two and you think of what interventions and therapies that are out there that rely on those two, like I said, opportunities are endless. I'll give one more example. My mom is 73. She has Parkinson's, right? And her side effects are freezing. Her lower extremities will freeze, right? And she's gone through 3 or 4 different drug cocktails, from just levodopa to now she's on Rytary, which is a combo of levodopa and carbidopa, I think, that's time release. And so every 8 hours, she needs to take her Rytary. The challenge is at around the 6-hour mark, she starts to freeze up, right? She gets that rigidity. And so she struggles for a couple hours. Well, in June, I put my mom on a Niagen IV. She did one 500 milligram infusion, and then she started taking the dietary supplement to complement it. And now she says she can go 10 hours without needing to take the medication and feeling the rigidity, the freezing, right? And then in July, she did her second infusion. So the second infusion, what we did different is we added glutathione. So if you think about it, to this question that Lisa has about this stack, glutathione and Niagen for boosting NAD complement each other well, because there's oxidative stress benefits with glutathione, and they actually support and upregulate each other. My mom did this second infusion. It was significantly better than the first. She said she felt for the first 24 hours like she didn't even know what Parkinson's was. She felt reborn. Wow. It was incredible, right? And so she said that it wore off, that euphoria wore off, and I'm being transparent with you, all over the first 24 hours, after the first 24 hours, but she still had all those additional benefits that I mentioned before. So those are 2 examples. There are just thousands and thousands of other ones out there like that. It's just a matter of, I encourage you all to just spark your own curiosity and then explore the hypothesis, and then you're just going to start noticing some of these values to these regenerative therapies that are out there.
So would you do the GSH before or after the IV? I usually do after, but wondering if it would help reduce IV side effects if done before.
Just glutathione. Typically at the end, right? Glutathione is most commonly administered either as a push at the end of the bag, right? Or it's in its own small bag by itself. For my mom, we did it as like a small saline bag with glutathione in there. I've done it personally myself, where I've done Niagen IV, and at the very end, just that slow push, just so that the viscosity doesn't hurt things on your veins. But to help with reducing the IV side effects, what I've encouraged some clinics to do is to like provide a drink like Perfect Aminos that have electrolytes. That tends to help reduce things, and or put the Niagen into a into a Myers cocktail bag that has some of these electrolytes in there.
We have time for maybe one more question. If not, we will wrap this up. We will send out follow-up information. We'll be able to provide you with pricing, states, and get you information on how you can get your first order in. Okay. Well, thank you so much, Eric and Jerry, for coming. You've done a wonderful job of explaining it. Obviously, we're looking forward to seeing all that it will provide for clients and patients. So we're really excited that we had so many people show up, because this is truly going to be something that we're looking at doing webinars to give you more and more cutting edge technologies and therapies to help your clients. So I appreciate you all coming.